We do way too much medical imaging. We spend millions of dollars each year, and for what? To reassure you? The truth is that screening and routine exams without specific reasons pose more risk than benefit to your health. I'm going to explain why we need to stop wasting this money focusing way too much on clumsy preventive medicine. 1.5 billion people worldwide live with chronic pain. If you enjoy my content, subscribe. It takes just 1 second. But most importantly, leave me a comment to let me know you've subscribed and share this video on social media. You can even create short videos from it. Help spread the message to reach and support as many people as possible. Finally, every month, I offer a free consultation to one person via video call or directly at my clinic. Let me help you better understand your neuromusculoskeletal pain and provide you with personalized tools to manage it at home. To participate, subscribe to my YouTube channel and leave a comment under the video mentioning that you subscribed and describing the issue you'd like to discuss. Finally, to double your chances, visit www.cliniquepsb.com, go to the health articles section, sign up for my clinic's health newsletter, and choose an article to leave a comment with your YouTube username. Good luck to all! The staggering expenses related to medical imaging tests, which burden our healthcare system heavily each year. Many of these exams are not always necessary and are often performed to reassure the patient or for other reasons. It is essential to understand not only the financial impact this creates, but also the consequences for patients' lives. So, stay with me to discover why it is important to reflect on the relevance of these practices and how we can all contribute to a more effective and responsible healthcare system. One of the reasons this topic is particularly close to my heart is the health situation in Canada. As many know, Canada has a publicly funded healthcare system financed by our taxes. Unlike the United States, where the wealthiest can afford to not worry about their health, often leaving the most vulnerable at the mercy of financial burdens that are passed down from generation to generation, exacerbating social inequalities over the years, the Canadian system presents a different issue. Here, everyone contributes financially, and everyone has access to care, which sometimes makes access to medical doctors or certain tests difficult due to long wait times. It is therefore essential to maximize our healthcare system to minimize unnecessary waiting lists and unlock access for those who truly need it. I want to talk about this because I see in my clinic how many people are sent to hospitals or semi-private centers for X-rays or MRIs, often without sufficient justification for such investigations. To illustrate this, I will give you 2 examples that matter to me. I will start with the 2 agencies in Canada, Quebec, namely the CNEST and the SAAQ, which respectively protect victims of workplace and road accidents. I will focus on these 2 agencies because, in my opinion, they are significant vectors of overdiagnosis. When a person suffers a workplace or road accident, these agencies systematically request a medical investigation to better understand the neuromusculoskeletal health status. Thus, without prior evaluation of the patient's health condition or justification for the relevance of these exams, an X-ray or MRI, or even both, are often ordered. It is then the role of the radiologist to prepare a report, and the physician's role to contextualize the information and share it with the patient. Unfortunately, it is at this stage that things get complicated. We then enter a realm of overdiagnosis, where anomalies may be discovered, even though the patient did not present specific symptoms related to these conditions. This burdens the medical backpack of these patients, amplifying their negative perception of their health by adding diagnoses that are often unrelated to the workplace or road accident. Clinically, a patient may receive a diagnosis of a grade 1 sprain, whether it is a muscular or ligamentous sprain, whether in the neck, back, shoulder, etc. When such a diagnosis is established, it means that other potential conditions have been ruled out. Based on the history, presentation of symptoms, and a clinical evaluation, there is nothing specific other than a sprain strain that would justify further investigation by another method of medical imaging. However, if a diagnosis of a sprain is made and the patient is sent for an X-ray without valid reason, it is possible that this X-ray will reveal benign anatomical anomalies that do not provide significant information about their health. For example, it may involve calcification anomalies in tendons, such as calcification in the rotator cuff tendons of the shoulder. If the radiologist detects this in their report, the physician may then suggest removing this anomaly, awkwardly associating it in an additive manner with the initial problem. We then enter a problematic zone because not only has a diagnosis been made on something that should never have been discovered and that does not cause real problems for the patient, overdiagnosis, but also unnecessary treatment for calcium washout may be proposed, which in the specific context of this fictional patient may present more risks than benefits to their health. Furthermore, it is important to remember that physicians are often overworked and struggle to see all their patients. They may not have the time to convey all the necessary information to ensure that the patient can give informed consent. This means they might not provide the important elements for the patient to make informed decisions regarding their health. Not only that, but examinations like X-rays and MRIs often lead to overdiagnosis of other benign degenerative anomalies, such as spinal osteoarthritis and herniated discs. It is crucial to understand that these degenerative processes can be discovered accidentally in areas of the body that have never experienced pain or problems in the past. Currently, these degenerative processes are considered potential risk factors for regional sensitivity. For example, if a person suffers from osteoarthritis or a herniated disc, they may be more likely to develop episodic sensitivity, chronic issues, or even episodes of intense pain periodically over the years, depending on the emotional and physical overload they experience. In contrast, a person without these risk factors may have more stable health. To illustrate this, let's take the example of smoking. Cigarettes represent a significant burden on the healthcare system because they significantly increase the risk of cardiovascular problems, cancer, etc. However, smoking does not guarantee that one will develop these diseases. It simply increases the chances. We all know at least one person who consistently defies the laws of nature, consumes soda, smokes, and does not engage in physical activity, yet lives to be 102 years old. These are exceptions, but they do not invalidate the general rule. Imagine a patient who, after a work or road accident, is diagnosed with a sprain, but is also informed that he has vertebrae fusing in his spine, indicating mild to moderate osteoarthritis, as patients often misinterpret these findings when they are poorly communicated by a physician who lacks the time for an in-depth discussion. On top of that, the patient is also told he has herniated discs. Given this anxiety-inducing information, do you think this patient will be able to return to work quickly and benefit from self-directed rehabilitation compared to someone with only a sprain? The patient receiving a heavy and complex diagnosis is likely to feel less autonomous regarding recommendations and conservative treatments, whether it involves chiropractic care or physiotherapy. Moreover, patients confronted with this type of overdiagnosis often establish negative associations between their health problems and their work environment. Every time they consider reintegrating into their workplace, they may be overwhelmed by negative thoughts, akin to the painful memory of a burn on a hot stove. This dynamic fosters the development of chronic pain patterns, making it nearly impossible for the brain to dissociate objective reality from the unique subjectivity of neuromusculoskeletal pain. These patients may never manage to reintegrate into the job market. During my conferences, when I discuss these issues with business professionals, I always advise them to modify an employee's functions upon their return. This approach helps prevent the individual from continually associating their work environment with negative health experiences. By doing so, we maximize the chances of the individual's reintegration and reduce the risk of developing chronic pain related to their past injuries in a harmful work environment. However, the association of negative thoughts, similar to what one might feel after burning their hand on a hot stove during childhood, is not limited to the professional environment. In fact, it affects all aspects of our lives. In my clinic, I frequently observe that injured athletes develop negative associations with certain movements, exercises, or physical activities. This can have disastrous consequences for their long-term recovery. It's a complex topic that deserves a whole video, but you're in luck. The link should go live there. In the meantime, share your story, your comments, your suggestions, or simply if you still have questions. Because with knowledge, you build your autonomy, navigating your health with more certainty.